Hello, I'm Nanette Santoro, Professor and E. Stewart Taylor Chair of Obstetrics and Gynecology at the University of Colorado School of Medicine, and I'm going to be presenting an ASRM Grand Rounds webinar on the climacteric. These are my disclosures. Over the next hour or so, the learning objectives of this presentation are to acquaint you with the hormonal changes that characterize the menopausal transition, to lead you to associate the common symptoms associated with these hormonal changes, and to identify the milestones of the menopausal process that are associated with disease risk or different health outcomes. So if you don't have a lot of time, I can tell you what my whole talk is about in the next 3 slides, and then I'm going to expand on it a whole lot more. So to get to the punchline, we've learned quite a bit about the menopause transition over the past 25 years from a number of worldwide studies. And the road to menopause has been defined largely in terms of menstrual cycle length. So prior to entry into the menopausal transition, women have regular menstrual cycles and normal ovarian reserve. As soon as they enter the transition, which is usually marked by a skipped menstrual period, but could also be marked by an increased menstrual cycle variability of more than 7 days, a woman has identified herself as having reduced reserve, and there's a defined time period that's heading her towards the menopause transition. This occurs at a median age of 47, but it is the more variable stage of the menopause transition and can happen as early as a woman's 30s. This does not necessarily mean that she's going to have menopause early. The late transition is a period of more prolonged amenorrhea with at least 60 to 90 days of amenorrhea, but less than 12 months. And that occurs at a median age of 49, but most women who enter the late menopause transition will be through the process and become postmenopausal within 4 years at the most. The menopause stages have been very carefully defined in the STRAW Staging Reproductive Aging Workshop, which was done first in 2002 and then repeated 10 years later to define these a little more firmly. And in addition to these menstrually based definitions, we also have some other hormonal correlates that are being better worked out over time. So the peak stages here, -5 to -3, I'm going to skip over. The early transition is considered stage -2. The duration is variable. Skipped cycle, 7 days changes, increasing FSH, but it's very variable cycle to cycle, and anti-Müllerian hormone or AMH, inhibin B, and antral follicle counts become noticeably low. While some women will experience hot flashes at this point, many will not. By the late transition stage -1, lasts about 1 to 3 years, and that's the lengthy periods of amenorrhea. FSH is more consistently elevated, and AMH, inhibin B, and antral follicle counts become very low. This is the hot spot where symptoms tend to ramp up between the early and late transition. Time 0, not shown on this slide, is the actual date of the final menstrual period, which isn't defined until a woman has become postmenopausal with 1 full year of amenorrhea. And just because it's unlikely that the postmenopausal period is completely monolithic in terms of hormones and health risks, it's been divided somewhat arbitrarily into 2 to 6 years and more than 6 years, but just the concept that there's an early and late postmenopause is helpful to keep in mind. So again, when we look at the road to menopause, regular to skipped cycles, but not that infrequent to very infrequent cycles, the hot spot is right here. The late menopause transition. That's when symptoms tend to ramp up. So what's the role of hormones in this process? The monotropic rise in FSH was first described in 1976 by Sherman and Kornman, and that's the hormone that we've come most often to associate with menopause. Subsequent studies by my group and others have shown erratic estradiol patterns with some estrogen levels going quite high, and evidence of the subsequent cycle follicle growth beginning before the period has actually happened in the prior cycle. Reduced progesterone production seems to occur across the transition, and menstrual cycles get shorter, mostly because the follicular phase becomes accelerated due to that monotropic FSH rise. Ovulation becomes a little less frequent, but that doesn't become very much less frequent until a woman is close to the end of her menstrual life. So from the ovary's point of view, this schematic shows a normal-sized ovary during what we call the mid-reproductive years with stable ovarian function. And when a woman reaches a critical level of follicle depletion, which is thought to be about 50,000 follicles, she then enters the transition, and her subsequent trajectory through the transition can be rapid, intermediate, or slow. And these lines or these slopes are really based on a number of demographic factors that I'm going to go through with you, but also some lifestyle factors. So we know that women with a higher body mass index don't seem to have a change in their timing of menopause, but women who smoke achieve menopause more quickly, and women, African American women, seem to achieve menopause more quickly. The second player in this equation is inhibin. So inhibin B, shown here, exists in a reciprocal relationship with FSH. And the concept here is that follicles don't exist in isolation, but they exist as a group. So follicles exist as a family, and when there's many follicles close together, as they are in that early activated state and are seen in when we count antral follicles, they're making relatively more inhibin, and this decreases throughout life because we know that that cohort of follicles shrinks. As the cohort shrinks, the restraint on FSH secretion is lifted, and we see higher and higher and higher FSH. So there's credibility to the inhibin hypothesis from several worldwide studies. And this is from the Melbourne study that looked at about 400 women going through the transition. And what you see in the middle are years surrounding the transition. Estradiol is relatively maintained. And then at around time 0, the final menstrual period, it goes down and stays down. And FSH does the opposite. So again, these hormones exist in a reciprocal relationship as well. However, the earliest signs of the transition, when women were looked at longitudinally, and the data is organized again to the final menstrual period, are a decrease in both inhibin A, a product of the dominant follicle in the corpus luteum, and inhibin B, a product of the follicle cohort. So in the early transition, low ovarian reserve and reduced inhibin restraint is manifest by lower AMH, which I have not shown you, but lowered inhibin B and A. And the net result of these changes are an intermittent increase in FSH because that cohort changes a little bit in size from cycle to cycle, somewhat erratic hormone patterns, and a shortening of menstrual cycles. So the usual patterns are broken down. Again, that low inhibin and high FSH tend to accelerate the period of follicular genesis. So some women will have follicular phases as short as 2 to 3 days, and then will go on to ovulate. Follicle recruitment seems to occur in the preceding luteal phase. And new dominant follicles can be ready to ovulate almost at the time of menses. These aberrant patterns are also associated with lower luteal progesterone, and the outcome is that women may often report that they feel as if they're on a hormone roller coaster, and there is some truth to that. We also know that follicles start out larger and grow more slowly, and on this graph you can see mid-reproductive women shown in the early, late, and mid part of the cycle and in the luteal phase. So these are mid-reproductive aged controls, and you can see small follicles seem to differ, and that would make sense because there's fewer antral follicles in women with aging, most evident in the early follicular phase of the cycle. However, the dominant follicles or the bigger follicles tend to be more pronounced early in the cycle, so again showing that accelerated follicle growth in these late reproductive women shown in the white bars, and just generally more large follicles at all cycle stages. So this shows some aberrant patterns of follicle growth. And this has been described by Georgina Hale as the luteal out of phase or loop cycles. And this depicts what the concept is, and this is estrogen on the y-axis and time and recruitment waves of follicles. So you can see cyclic recruitment waves on the bottom of follicles. And here's a woman having her menses, normal rise in estrogen, a normal dominant follicle, and a normal ovulation. And then what happens on top of that is there's a second wave because of that high FSH. that follicle, a second follicle grows, and you see a superimposed estrogen curve on top of the first one. And this is what she has called the out-of-phase dominant follicle. What this does is it potentiates the amount of estrogen around, so now you've got some very high estrogen levels, and you get an out-of-phase ovulation. So women notice their cycles are more irregular, their progesterone patterns are more irregular. And this is a transition hormone pattern in a single perimenopausal woman who collected urinary hormones, and this shows a 6-month window of time. And what you see on the left and right in these bars are what are normal ranges for mid-reproductive aged controls. And over the course of this 6-month period, you can see the PDG pattern here. There's 1, 2, 3 ovulations that occurred, and only one of them really is falling within the normal range. The others are a little bit lower. And in one of these anovulatory windows that you can see here, we have one of those escape patterns where urinary estrogen just rises to about 3-fold higher than what is normal. And that was preceded by a big bump in FSH. So some of the clinical correlations here are that, again, hormone levels more erratic, cycles closer together. Women will complain of symptoms of PMS and irritability in the initial stages of reproductive aging. And in the SWAN study, about almost 1/3 of women complained of increased irritability. And it's likely this is linked to these hormone changes. With further loss of reserve, then cycles get skipped, but only then as women get into that late transition do they have consistently low estrogen. And again, this shows whole cycle daily patterns of hormones, and the open symbols show older women. And in the older women, you can see here higher FSH throughout the entire cycle. That's the open triangles. And these are mid-reproductive aged women, so you can compare those FSH patterns. LH, there's less of a dramatic difference. There's some slightly higher LH at the end of the ovulatory rise in LH. And estrogen patterns, when you look at daily estradiol, the open symbols here show you estradiol, and the closed show you the mid-reproductive aged women. So not much of a difference in estradiol patterns, but progesterone is markedly different. So in the older reproductive aged women, we see decreases in progesterone, particularly in that late second half of the luteal phase. And associated with those, again, comparing the open to the closed symbols, there's reduced inhibin B in the follicular phase of the cycle. And we see some reductions in inhibin A, kind of in parallel with those progesterone decrement. When we look at follicular and luteal phase urinary hormone changes as the final menstrual period approaches, these are daily urinary hormones that were taken in a cohort of women from the SWAN study. You can see that in the luteal phase, progesterone metabolites go down. No change in follicular phase because largely that's just reflecting adrenal hormones. And we see that follicular phase FSH goes up, less so luteal phase FSH as women approach time 0, the final menstrual period. LH also tends to go up, perhaps not as dramatically as FSH does. And we don't really see large changes in estrogen until women get close to the end of their reproductive lifespan. When you look at the proportion of cycles that have an ovulatory type pattern characterized by a robust rise in pregnenolone, again from the SWAN study, this is a cohort that started out of almost 900 women. By the time we get down to here, we have fewer that persisted in the study, but you can see that almost all cycles are ovulatory in these normally cycling women when we get to about a decade before the final menstrual period. And they go down, but they go down quite slowly. So by the time a woman is minus 2 years from her final menses, she's 50-50 likelihood of ovulating. And in that year right before she attains her final menstrual period, that 3/4 of the cycles are anovulatory. So anovulation happens, but it tends to be a later change. And interestingly, in SWAN, some of the very last menstrual cycles of a woman's life appeared to be ovulatory with a relatively robust rise in progesterone. So now that you know everything about hormones, let's move on to part 2, which is the natural history of some common menopausal symptoms. And again, we are blessed with several wonderful worldwide studies that have given us longitudinal data on what happens to women as they traverse the menopause. The appearance and duration of common symptoms are well known. But what's important to keep in mind, and which also is important in terms of therapy, is that we really don't know much about some of the uncommon symptoms or whether there are biologically susceptible subgroups, and these are almost certainly the case. There's probably a number of symptoms and subgroups that we will learn about in coming years. So the old thinking about hot flashes was that this was a transient phenomenon, and that was really based on putting a lot of cross-sectional study data together, and that it would last for about 2 to 5 years. But from studies like SWAN and the Pan-Ovarian Aging Study, we've learned that for many women, hot flashes can last for 10 years or more, and they can continue to be quite severe. This risk varies with demographic and biological factors. And of course, the other important thing is that there is a small subgroup of women for whom hot flashes never go away, and they just stay as severe as they were when they began their transition. 2 years after the final menstrual period, almost half of women in SWAN had moderate to severe hot flashes. About 1/3 of women persisted with moderate to severe hot flashes more than 9 years after menopause. So when do they start? It really depends on how early you look and exactly how you ask the question, but anywhere between 1/5 to almost 3/4 of premenopausal regularly cycling women will report hot flashes, and this is also dependent on race and ethnicity. This prevalence varies several-fold by ethnicity, with Native American women in the Reed study reporting the highest proportion of women with hot flashes. The prevalence increases as women enter and traverse the transition, and the peak prevalence spans that year that straddles before and after the 2-year period straddling the final menstrual period. So just to drill down on that a little more, among over 1,500 premenopausal women, they had regular menses. Hot flashes were reported by 3/4 of the Native American women, 2/3 of the Black women, similar proportion of white women, and you can see the prevalence going down as we go to Hawaiian Islanders, Vietnamese women, Filipino women, Japanese women, East Indian women, and Chinese women, such that they are less than half the amount of self-reported hot flashes than are the Native American and Black women. So factors that influence hot flashes, the ethnic groups most severely affected appear to be African American and Native American. BMI is related to hot flashes, but not in a straightforward way. Obese women will experience worse hot flashes before the final menstrual period, but after the final menstrual period, when ovarian estrogen drops out, obesity appears to be protective. Anxiety and depression are also associated with worse hot flashes, and higher FSH levels and lower estradiol are associated with worse hot flashes. When you look by age group in the Women's Health Initiative, and this is over 10,000 women, to see how long they persist, you can see that in the 50 to 54-year-old age group, 24% report them, 21, so there's a slow decline here. 10% still reporting at ages 60 to 69, and in the 70 to 79-year-old age group, 5% of women are reporting. Now, importantly, these data from the WHI involve women who agreed to be randomized to hormones. So you'll notice that the prevalence of hot flashes is a little lower in this group, but that's to be expected. Hot flash duration, again, dependence on BMI and age at onset has been observed as well in the Pan-Ovarian Aging Study. If hot flashes start before age 44 or early in the transition, they are more likely to persist for a decade or more, and they are more likely to be severe. Black women with a BMI under 30 appear to have the longest duration of hot flashes, and that median duration was 12 years in this study. Women with higher BMI have a shorter overall hot flash duration, especially if the age of onset is over 44 and they appear in the late transition. And the duration of severe hot flashes were lowest in Caucasian women in this BMI greater than 30 group if the onset was later than age 44 and they didn't appear until the late transition. And those women had the most merciful duration, which was 2 years. And from SWAN, again, asking about self-reports, and it's important to note all these questions are asked a little bit differently. In SWAN, the question was asked about hot flashes over the past 2 weeks. We can see that from premenopause, completely regular cycles to that early transition, there's a little bump on the average, African American women showing the most significant one. But as women go from the early perimenopause to the late perimenopause, that is really where we see the biggest rise. There's a small increase as they progress to postmenopause. And these data that look longitudinally at the SWAN study and look at the total duration based on when they appeared, women with a premenopausal, so before any cycle irregularity happens, if your hot flashes have already been present, you're likely to have the longest duration. The women with the shortest duration, late perimenopause or postmenopausal appearance of hot flashes. So not a surprise, but look at even these groups have a total vasomotor symptom duration of somewhere between 3 and 4 years to 5 or 6 years. So even with a late presentation, this is not a short-term issue. By race ethnicity, you can see again, similar to what other studies have shown, African American women, longest duration, and this again shows more than 10 years duration, and Chinese women showing the least duration. Half of the Chinese women had no more hot flashes after 5 to 6 years. And this just shows the persistence of symptoms. So this is a little bit different. The prior slide showed you the total duration, and this is persistence after the final menstrual period is attained. And those women that have the premenopausal appearance are again likely to have the longest persistence after the final menstrual period. And this shows you that about 50% will still have hot flashes almost a decade after. Race ethnicity, again, similar slide, almost a decade long for African American women and much, much shorter for Chinese women, with other racial ethnic groups falling in between. So the symptoms associated with the early transition, again, there's that beginning of hot flashes. They start to increase in frequency or they appear for the first time. Sleep gets worse, and sleep has received more and more attention, although we still don't fully know all of the consequences. Women with less sleep have increased aortic calcifications, greater risk for hypertension, and increased BMI. Headaches worsen, so women who have migraines are likely to have them get worse before they get better. And as mentioned before, irritability or dysphoric mood goes up. So when we look at sleep, the proportion of women who report trouble sleeping based on cycle day, and these are women who collected daily urinary hormones so we could place them exactly in their cycle, and they kept a daily diary. Before the onset of any menopause changes, you can see there is some cyclic variation. So at the beginning and at the end of a menstrual cycle, trouble sleeping went up, but you can see that as they entered the transition and became perimenopausal, their sleep got worse. So more women reported poor sleep, even in that middle part of the cycle when it was better for those premenopausal women. BMI is also related to sleep duration, so women with a higher BMI based on diary and actigraphy, so both of these measures show the same type of relationship, a little steeper when you look at actigraphy. These women tended to get less hours of sleep during the day, and you can see sleep durations as little as 4 hours a day. When we look at migraine headaches, we now have a bit of an explanation for that, because when you look at patterns of mean estrogen, and this is estrone conjugate, so it's urinary estrogen metabolites in women from the SWAN study, and you look at the days after the luteal phase estrogen peak, so this is really sort of the mid-luteal phase onwards, we see evidence that women who ever reported headaches, whether or not they had a headache in that cycle, have this estrogen drop. So this implies that hormones are associated with and may be a precipitating factor, but are not necessarily causal for migraines, and supports the practice of supporting women with migraine headaches with some luteal phase estrogen. You can see also that the progesterone, no matter how we looked at it, we didn't see any difference. And when we looked at it in relation to progesterone secretion, we didn't see a difference between the groups. So it really was estrogen that declined more rapidly in the migrainers. Mood is also affected by the menopause transition, and an increase in adverse mood is most likely in the late transition. The women who've had minimal pre-existing symptoms appear to be most vulnerable because they will have a new onset of depression, and it's something that clinicians need to be alert to. In addition to women who have had prior episodes, who will often walk into the office and tell you they know their mood is deteriorating, you may get patients for whom this is their first life experience. And there is some evidence that this is hormonally based, because experimental induction of perimenopause with agents that reduce ovarian reserve, like VCD, decreases both progesterone and dihydrotestosterone and increased anxiety symptoms in an animal model. So when we look at women with high depressive symptoms, and this is based on a survey, the CES-D, and a CES-D score greater than 16. So this is not a diagnosis of depression. It's just a measure of depressive symptoms. I'm going to show you more of a formal diagnosis of depression data later. But as women go into the early perimenopause versus pre, so they begin to have that cycle irregularity, their risk of increased depressive symptoms rises and rises further again in that hot spot, that late perimenopause. So as they enter the late perimenopause, it's even higher, stays high for a few years after the menopause is over, and then it goes back down. But hormone therapy users also seemed to not be spared. Hispanic race ethnicity was associated with more depressive symptoms, more higher prevalence or greater odds, as was being Japanese American. Women who experienced financial strain, as defined in the SWAN study as having it hard or very hard to pay for the basic necessities of life, and women who had less positive attitudes towards menopause or used psychotropic medications, or who had stressful life events, were not surprisingly more likely to have depressive symptoms. The major depression is different. It's a much more severe entity, and that will typically require medication. But almost 9% of women years of observation in SWAN, we saw episodes of major depression. Significant risk factors for an episode of major depression is a prior major depression, and again, very stressful life events, use of psychotropic medications, entering that late peri or post-menopause compared to pre-menopause, and the two ethnicities that associated with depressive symptoms, Hispanic or Japanese. Genitourinary syndrome of menopause is another common climacteric symptom that we see, and based on, again, how the question is asked and who the population is, about a quarter to half of women will report being affected by some symptoms of GSM. It is not well studied longitudinally, although that is underway in the SWAN study, and these symptoms do seem to worsen in the late menopause transition. There's some evidence that they may worsen over time, but there is more controversial evidence about whether or not they actually worsen without treatment. It's also been suggested the condition is undertreated. So now let's go to part 3. How do we predict health challenges in climacteric women? Well, let's look at the common problems that cause health compromise in midlife and aging women. And far and away in the United States, this would be metabolic syndrome, type 2 diabetes that happen in midlife to older age coronary heart disease and cardiovascular disease, and midlife to older age cancers, and osteoporosis and fracture, mostly a disease in older age. So how do we predict these, prevent them, and set people on a course that'll minimize their risks of all of these diseases? Well, first, I start with what I call the core 4 symptoms. These are the symptoms that are most reliably likely to be attributable to menopause and are most likely to be relieved by hormones. And they include hot flashes, adverse mood, poor sleep, and vaginal dryness or GSM. But let's go back to some of the other diseases. And when we look at dysmetabolism, if we put our preventive hats on, when does this start? Well, about 6% of women in SWAN had prevalent metabolic syndrome at baseline. And these were women that began in the pre or early perimenopause and had to be 42 to 52 at enrollment. By the time of the final menstrual period, almost another 14% had new onset of metabolic syndrome. So adding to this then, we have about 20% of women that had metabolic syndrome by then, and it was related to their free testosterone index. We watched metabolically benign obesity progress to at-risk obesity in 43% of the obese women over 7 years of time. And having a higher BMI and impaired fasting glucose were the biggest risk factors for progression. But the biggest mitigating factor was physical activity. So that's important to keep in mind when advising patients and counseling them on lifestyle. We also noted that depression and childhood abuse influenced the onset and progression of dysmetabolism. And again, very important to keep in mind because we tend to underestimate the social determinants of health as we tend to overestimate the ability of hormones to work magic in these kinds of settings. Let's look back at coronary heart disease, another big health problem and cause of mortality in women. We see very, very low coronary calcium and carotid intimal medial thickness. These are intermediate measures of heart disease risk later in life. In eumenoric women, they are essentially zero for coronary calcium and very, very little carotid intimal medial thickness until the menopausal transition starts. With the onset of the late transition, we begin to see annual accrual in carotid intimal medial thickness. And we see this more rapidly in women who are at metabolic risk to begin with. And this seems to be linked to adverse changes in SHBG. We also see cardiac fat associated with subclinical CVD, but we currently know little about this relationship to either hormones or to metabolism. But these are all strong intermediate risk markers for subsequent atherosclerosis. Lipoproteins also change adversely in association with the menopause transition, and even though we may see mild changes in HDL, we do know that HDL particle size goes down and HDL may become less protective, along with increases in LDL and a decrease in particle size, making LDL more atherogenic. So even without changes in the numbers, the profile becomes more adverse. The third big health risk to women are cancer risks, and there is linkage of breast, colon, ovary, and endometrial cancer to hormones, also to dysmetabolism and to obesity. While linkages are arguably stronger, especially for breast cancer, to genetics, and as we uncover genetic syndromes that confer risk, we'll probably get better at being able to risk handicap patients. We do know some of these linkages. It's difficult to predict risk with brief hormone exposures, but we do know that some interventions that we do change cancer risk. So, for example, as little as 6 months of oral contraceptives can give a 10-year benefit of protection against ovarian cancer, making the perimenopause a decent time to consider intervening with oral contraceptives if women are symptomatic. During the menopause transition, we know that estrogen treatment alone in women with a hysterectomy increases risk of ovarian cancer, and estrogen plus progestin increases the risk of breast cancer over time. But other factors that tell us as well that estrogen exposure or the lifetime of estrogen exposure is meaningful is that women with both an early menarche and a late menopause tend to also have higher risks of breast cancer. Finally, osteoporosis and osteopenia are diseases we want to prevent, but they have their origins in the menopause transition. And as mentioned before, with symptoms, this process is similar. So there's a clear-cut linkage of that late transition, that when prolonged amenorrhea occurs is the point of origin of estrogen-related bone mineral density loss. Now, not all bone loss is due to estrogen, but a substantial portion of it happens in a 5 to 7 year window that surrounds the menopause transition, but begins at that late menopause transition. So it makes sense to start thinking about this and investigating it further to see if we can identify women who may be at the most risk at this point, where we might be able to intervene more effectively as opposed to what we're doing now. Universal screening for bone density is not recommended until women are about 15 years past this milestone at age 65, but we've already missed the rapid bone loss that's happened. So women at the highest risk are going to lose the most bone at this period of time. So how do we identify the women at the greatest risk? Well, clearly what you see here, and one of the major contributions of the SWAN study, was showing that bone density is maintained. And you can see bone density change here in the lumbar spine and by ethnic group. So this is by menopause stage. And in the pre and early perimenopause among all women, there's absolutely no change based on race ethnicity that is significant. None of these differences are statistically significant until a woman hits that late perimenopause. So this shows that that prolonged amenorrhea and that absence of estrogen is causing related to the bone loss. At least it's the best causal inference you could possibly have in an epidemiologic study. That rate of loss is maintained through the early postmenopause, and this just shows the change in grams per centimeter squared per year. And again, shows the same thing in the lumbar spine and the total hip. So in this slide, you see the change in grams per centimeter per year, absolutely nothing happening until women hit that late perimenopause and are postmenopausal. So the model for bone loss that has emerged as a result of SWAN and other studies is that the transmenopause, this period from about -1 to +3 in straw stages or years from the final menstrual period, are when women will lose bone density. Concurrent with that, we see a rise in markers of bone resorption, urinary telopeptides, and we see this drop in estradiol and rise in FSH. So if there were a way to attenuate bone loss during this critical period, we might be able to make greater inroads into the early diagnosis of osteoporosis. And shown another way, this is the number of months before or after the final menstrual period. And this is a smoothed plot of lumbar spine bone density. And the lumbar spine is more estrogen sensitive than the hip, but you can see really a very precipitous decline that happens during this period of time. And then this is at the 60-month mark, so that's about 5 years after the final menstrual period, it begins to level off. One of the other long-term risks that is a cause of concern, but may be less likely linked to hormones, is dementia, a major cause of morbidity and mortality in elderly women, and for sure a major fear of many of our patients. Although hormonal risk factors have long been sought, we do not have strong evidence that exogenous or endogenous hormones influence the risk in naturally menopausal women. Surgically menopausal women, or women with early surgical menopause, especially those who have risk-reducing surgeries, may be at higher risk. But randomized controlled trials of hormone therapy fail to confirm benefits that have been seen in observational studies. So similar to our situation with heart disease and hormone therapy, we have a similar dilemma when we look at vascular and Alzheimer dementia, because the observational studies show a fairly dramatic decrease in risk, but the clinical trials do not. So as we approach the end of the talk, I want to share some new data with you, because one of the charges of the SWAN study, which was a longitudinal study of the menopause transition, was, is there a way to find a blood test that would help women predict menopause rather than going through a painstaking menstrual history and trying to reconstruct these ballpark estimates? Can we do better than that? And finally, I'm happy to say the answer seems to be yes, and that an ultrasensitive anti-Müllerian hormone assay can be used to help predict the final menstrual period. So if the assay is sufficiently sensitive, it's been shown by Finkelstein and others with an assay using a lower limit of detection of 2 picograms per milliliter, that the final menstrual period can be predicted within 9 months based on age and a single AMH level. We don't know yet, but based on other studies, such as the Panovarian aging study, using a less sensitive assay, multiple AMH levels may predict the trajectory of AMH over time and may add to this. The Panovarian aging study was able to predict the time to menopause to within 6 years, but that is not much better than menstrually based definitions. However, a well-timed AMH that is informative based on age may be able to do that. And what you can see here are some of the data that show the relationship between low AMH and time to menopause. So this is the time to the final menstrual period in months. Women with an undetectable AMH achieved menopause within -12 months, so within a year. As AMH got a little bit higher, you could see that there were some differences, and you can see here that a very high AMH over 100 was pretty predictive that a woman would not go through menopause. We performed the same predictions with FSH, and while FSH performed well, with the highest FSH levels being predictive, it did not perform as well as did AMH. And it was not as good at excluding menopause within a certain time period. A high AMH was better than a low FSH at excluding the likelihood that a woman would go through menopause. So in summary, the menopause transition has now been examined in a number of worldwide longitudinal studies that have yielded useful information on its physiology and its symptomatology. We have a basic picture of the linkages between reproductive hormones and symptoms and how they fit into the larger overall picture of aging. But there are many embellishments to be added. We have much to learn about how metabolism interacts with reproductive hormones to change a woman's risks and health. We have genetic information that we need to add, and perhaps pharmacogenomics to round out the picture and predict who's most likely to become symptomatic and what the best treatments might be. So changes in hormones, primarily estradiol at the time of menopause, seems to interact with the aging process to alter health risks. Some of these relationships are unidirectional and fairly simple, as in the case of bone resorption, estrogen good, no estrogen bad, but others are more complex, as you've seen. Some are bimodal, biphasic, or may even be dichotomous. And things like the relationship between BMI and hot flashes show us that some of our relationships between how hormones may be related to metabolism are complex. And these long-term health risks may interact with one another, but they certainly merit chronic attention and identification at the time of the menopause transition. And with that, I thank you all for sticking with me to the end and hope that you've enjoyed the presentation.